Hi, this is my celebrity wellness presentation on Seth Rogen. He is a 37-year-old male, Caucasian, and his profession is an actor slash comedian. This patient complains of nausea and stomach pain on and off for the last 2 weeks, and having to get out of bed at nighttime to pee multiple times. His location is in the mid-epigastric area. It's intermittent. States he notices his epigastric pain upon waking in the morning and prior to meals, with episodes occurring at random. He describes the nausea as bothersome feeling, like he wants to dry heave and vomit, but can't get anything out. Associated symptoms include nausea and frequent urination. He states his symptoms are aggravated by a decrease in sleep patterns from the frequent getting up at night to use the bathroom, and denies any relieving factors. Yeah, he denies any food intake that makes the symptoms worse. He denies vomiting. He denies taking any medication and admits to taking OTC supplements daily. Timing of the episodes is infrequent. Feels more nausea if he does not eat at all or when he drinks water. If he were to grade the severity of his abdominal pain, it would be a 2 out of 10. Nausea graded at a 4 out of 10 during episodes. He denies any fevers, chills, congestion, night sweats, visual changes, headache, vomiting, or decreased appetite. Admits to recent weight gain and fatigue. His vital signs are as followed. His blood pressure is 137/78, heart rate 88, respiratory rate 18, temperature 98.6, oral. His past medical history includes LASIK surgery in 2007. He had a benign parotid gland tumor removed in 2009. His cheek and nasal fractures occurred in 2010, and he's allergic to dogs. He denies any medication or supplements often, but he does admit to supplement usage. Fish oil daily, Androstax X, which is a BCA supplement, and then he uses ladder supplements, which include plant protein and pre-workout. His social history, family history, and immunization are as followed. He admits to wine on occasion, 3 glasses per week. His smoking occasion is cigars, infrequently, only on occasion, and drug usage is marijuana every day. His mother had high blood pressure, hyperlipidemia, and breast cancer. His father's medical history is unknown. And his immunizations are up to date. Influenza is annual, Tdap 2009, varicella in 1984, MMR in 1985. In terms of gender-related care, his prostate exam has never been performed. He did have a PSA blood test performed for annual lab work, but it was within normal range at 2.1. His last testicular exam was in 2015. No previous history of colonoscopy. His eye exam, hypertension screening, lipid screening, HIV and STI screening are all up to date, all recently done in 2019. His review of systems is as followed. Some pertinent positives included patient admitted to a weight gain of 20 pounds. On his HENT review of systems, he admitted to increased thirst and drinking a lot of water. He also admitted to recent fatigue. He also admitted to the mid-epigastric pain during episodes at 2 out of 10, and then also with nausea. On his GU review of systems, he had some urinary frequency, urgency, and nocturia. His physical examination is as followed. All within normal limits. Concerning his GI system, I did do a full head-to-toe examination, especially on his GI, but there was no actual abnormalities there. So his pharmacological treatment plan centered around a primary diagnosis of diabetes mellitus type 2, I put him on metformin 500 milligrams PO twice daily, taken with meals. And he's to follow up with his medication to see what his A1C is. I also put him on Jardiance 10 milligrams PO once daily, taken with meals, also to be followed up on his hemoglobin A1C. His non-pharmacological plan included weight loss and exercise. Usually, type 2 diabetics should initiate moderate to high intensity exercise for at least 150 minutes per week, spread over a minimum of 3 days a week. This amount of exercise is proven to increase insulin sensitivity, but to caution on hypoglycemia. An emphasis on diet and meal planning is also in the cards for a diabetic. The Mediterranean diet is basically a plant-based diet, which is well known for its health benefits in cardiovascular disease, cancer, and in this case, diabetes. The diet consists of a high amount of olive oil, vegetables, legumes, whole grains, fruits, and nuts, and also a moderate amount of poultry and fish, with a low amount of whole fat and dairy products, along with red meat. This helps with achieving glycemic control, reducing insulin resistance, controlling BMI, blood pressure, and cholesterol. Anticipatory guidance is centered around tobacco and smoking cessation. He does admit to cigar usage and marijuana usage, so this is also a primary prevention. Exercise, of course, muscle training, and weight bearing, because he's at risk, an increased risk for heart disease with a family history of hypertension. Eating a heart-healthy diet to reduce cardiovascular risk for disease, and vaccinations. He could get a Tdap since it was in 2009, so within 10 years, and influenza when in season. Secondary prevention is centered around hypertension screening, HIV screening, and depression screening, usually for all patients during an annual wellness exam. Follow-up plan would include starting the medication for glycemic control to try and prevent all of his symptoms. Glucometer strips and BP checks to monitor for hyperglycemia and blood pressure control. Diet, exercise, and water intake to increase his insulin sensitivity. I want him to return if worse. This is always the case when patient is on medication therapy. And then also to return in 2 to 3 months for his hemoglobin A1C redraw. These are my differential diagnoses. As you can see, type 2 diabetes mellitus. His differentials include these. He was complaining of the nausea. I would suspect gastritis with no vomiting. And then peptic ulcer disease. The rationale would be the nausea. The pain, which would be 1 to 3 hours after eating usually, but this may follow with nausea, vomiting, discomfort, flatulence, and significant loss in body weight, so this is less likely. A urinary tract infection would be a suspicion as well, just because he complained of frequent urination. No painful urination, but he does admit to nocturia. And these are my references as followed. Thank you.